We have audio. Hi, Dr. Fossey. Can you hear me?
I can. Good morning.
Good morning. We have you loud and clear if you want to go ahead and share your screen.
Excellent. Okay, it's saying that host has disabled the
Give me 1
screen.
second, sorry.
Yep, no worries.
Try it again for me.
All right, perfect.
Okay. Are you good?
Yep, I'm good. Does it look okay on your end?
It looks great.
Okay.
Give me just a second. We're going to get back from break. I will introduce you and you'll be ready to go.
Okay, great. And are you Ashley? Sorry, or
And
Jessica? Okay, great. Nice to meet you.
you too. Okay, if we can get our attendees to start finding their seats, please. Our 5-minute break is coming to an end. If we can please start finding our seats. With the Zoom. Kelsey, are you ready?
I am. Thank you.
Okay. So
okay,
we are
if
going.
everyone can please go to their seats, we're getting ready to start the Zoom session. Thank you.
Thank you, Melissa. So our next presenter this morning is Dr. Chelsea Fossey, and she is a Senior Health Policy Analyst at the American Dental Association Health Policy Institute. She graduated from Rutgers School of Dental Medicine and completed a general practice residency at Helen Hayes Hospital, working with adults with intellectual and developmental disabilities. She's obtained her Master's of Public Health from the Mailman School of Public Health at Columbia University and completed a dental public health residency at Jacobi Medical Center, New York City Health and Hospitals. At HPI, Chelsea leads the health policy analysis for critical issues related to Medicare, Medicaid, the Affordable Care Act, and other public health issues. She's also responsible for researching and analyzing policy changes that impact dentistry, oral health, and the broader healthcare landscape. Help me in welcoming Chelsea Fossey.
Thank you so much, Ashley, and it's wonderful to be joining you all. As you all know, please feel free to interrupt me at any time if we're having any difficulties technology-wise, but I'm so glad that it was possible to join you even remotely today. So as you've heard, I'm Chelsea Foss. I'm a dentist, and I joined the Health Policy Institute, or HPI, as it's affectionately known at the ADA and within the dental community, a couple years ago. So now I spend my days surrounded virtually mostly by economists and statisticians, other researchers. We analyze the latest and most credible data to inform critical policy issues and drive sound economic and health-centered decision making. So all of our work is really meant to help inform and guide not only dentists, but policymakers, and especially at the state level. So that's why I'm so happy to be here today. I'm really grateful for this opportunity, and I sincerely hope that you all find utility in this, or at least it sparks some interest in some areas. So today, we'll be discussing 3 different but very interrelated areas. So we'll talk about some of the bigger picture trends that we've been seeing in dentistry that really predate the pandemic, and in some cases maybe are being accelerated by the pandemic. We'll review some findings from our team's most recent polling of dentists on the economy and emerging issues in dentistry, including a discussion on the current staffing and workforce shortage challenges that are being felt across the nation. Lastly, we'll look at some Medicaid-related research that our team has done, specifically on the importance and cost of Medicaid adult dental benefits, as well as a quick look at dentist participation and reimbursement rates. And we'll see how Missouri stacks up. So let's get going. I may fly through parts of this in hopes that we can cover it, still leave time for Q&A, and not push the next speaker back too far. But we can certainly revisit this information. The slides, if they haven't already been distributed to you, they absolutely can be. And I'll be sharing some links that hopefully are helpful for anybody who's interested in further details. So let's go. Solo practice in dentistry has been on a downward trend for many years. I don't think this is too surprising to many. In 1999, nearly 2/3 of dentists were in solo practice. And in 2019, half of dentists were in solo practice. So that practice model is giving way to newer structures and practice sizes, and we'll see how this plays out over time. We have more data coming on that very soon. But compared to the national average of about 50% of dentists being in solo practice, Missouri has a slightly greater share of dentists still in that practice model, roughly 55%. So working in group practices and being affiliated with a DSO probably is on the rise, right? And that indeed is the case. Again, we're actually releasing some new data on this next week that's still in the final stages of being crunched, but I'll provide some information about what's coming soon too. So in 2019, over 10% of dentists were affiliated with at least a DSO, or dental service organizations. The bars at the bottom of this slide show the share of dentists in each state who are affiliated with the DSO. So again, we see lots of variation in practice consolidation, at least by DSOs, by state. But Missouri was right in line with the national average at 10.1% compared to the 10.4%. Spoiler alert, with what we're seeing from the 2020 and 2021 data is the share of dentists affiliated with the DSO has gone up pretty significantly, even in the past couple of years. And perhaps not surprisingly, younger dentists are more likely to be in DSOs, as are female dentists. Okay, here we have some information from ADEA, the American Dental Education Association. And we're zooming in on that new dentist population, the very new dentists, those coming right out of school and who indicate that they're going into private practice. So the folks that we're considering here are not those who are going into residency or have any plans along those lines, but those who indicate that they are going right into practice. And in the 5 years from 2015 to 2020, the share of dental school grads with plans to join a DSO shot up from 12% to 30%. So it went from roughly 1 in 10 to nearly 1 in 3 in just 5 years' time. Okay, now getting into some demographics. Compared to just 40 years ago, or heck, even 10 years ago, a much higher share of dentists are female. In 2019, we saw the tables tilt as females for the first time made up a greater share of dental school students than males. In terms of practicing dentists, about a quarter, 24%, of dentists were female in 2010. And just 10 years later, in 2020, female dentists made up more than a third of the actively practicing dentist workforce. So we've clearly seen these gender shifts in many other sectors too. In medicine, these shifts have been about 10 years ahead of dentistry. It's really interesting to look at the data from the 1970s in medicine. Really closely matches up what we saw in the 1980s in dentistry in terms of more females entering the field. These demographic shifts have implications for dental practice patterns too. So as we saw with solo practice, which was the predominant model, practice model in dentistry historically, practice ownership overall, so even even in partnerships, has been on the decline. So let's first look at that green box on the far right, representing all dentists. In 2005, which really seems like yesterday, 85% of dentists had an ownership stake in their practice. But that dropped by about 10 percentage points less than 15 years later in 2019. So in 2019, about 83% of male dentists were in ownership positions. That's shown in the center here in the teal color, as compared to just 63% of female dentists shown in the burgundy on the left. And this has held true over the years. Female dentists have been less likely than male dentists to own their practices. Okay, what other demographic shifts are we seeing in dentistry? HPI released a data series on racial disparities in dentistry last year. And in that data series, we described the racial and ethnic composition of the dentist workforce in the US, the demographic makeup of the student population and associated debt levels, cost barriers to care among patients by age group and race and ethnicity, and utilization of dental care also by age and by race and ethnicity. We're going to zoom in on the workforce and pipeline today. So on the right here, we're looking at the racial breakdown of the US population at several points in time. So at the top of the slide, we have the historical view starting at 2005, which again, doesn't seem like all that long ago. And then if you move downward, the last set of bars at the bottom of the slide is data from 2020. And at that time, 2020, 60% of the US population classified as white, 18% roughly is Hispanic or Latino, 12% about are Black, and about 6% are Asian. Okay, so that's the US population 2020. On the left is a look at the dentist workforce. And again, let's just go right to the bottom, 2020 data. We have a higher share, about 70% of the dentist population who are white as compared to the US population, which is, again, about 60%. There's a much greater share of dentists who are Asian relative to the US population, as you can see in those teal lines, and a much smaller share of dentists who are Black or Hispanic compared to the US population. And that's shown by the green and the orange bars here. So what is this telling us? The dentist workforce does not mimic, it does not reflect the US population, the people it serves. There's been a shift, and we've seen a decrease in the share of dentists who are white. But most of that diversification, it has been largely due to an increase in the share of dentists who are Asian. There's been little change in the share who are Hispanic, and in the general population, that's been the largest driver of population growth or population shifts. There's been zero change in the share of dentists who are Black. So the dentist workforce, again, may be becoming less white. That's almost entirely due to growth in the share of Asian dentists, but underrepresentation remains for Latino and Black dentists. All right, let's take a closer look at the dentist pipeline, dental students. Let's look at the distribution of first-year dental school enrollees by race. And again, let's go down to the bottom of the slide where we see 2020 data. There's a smaller share of white dental students in 2020 shown in the burgundy bar compared to 2005 up top with the burgundy bar. So the dental student body overall, if you compare all of these, has diversified over time with increases in Asian students, the share of dental students who are Asian shown in teal. Nearly 1/4 of dental students in 2020 were Asian compared to comprising about 6% of the US population. There's been some increase in the share of Hispanic or Latino dental students, but there's been no change in the share of dental students who are Black, and that's shown by the orange lines over time. So why is this important? What are the benefits of a diversified workforce? We've learned that there are certainly some racial differences in practice patterns in dentistry. For example, non-white dentists disproportionately treat underrepresented minorities. Black dentists are far more likely to participate in Medicaid and to serve low-income populations. And in fact, white dentists are the least likely of any racial or ethnic categorization of dentists to participate in their state's Medicaid program to treat Medicaid enrollees. So the research does support the idea that there are implications for access to care when we diversify the dentist workforce. So lastly on this, let's look at some data on student debt, which is clearly a huge stressor affecting such a large share of not only the dentists of tomorrow, but really the dentists of today too. And it's incredibly important that we understand how this all affects our current and prospective new dentists and what sort of practice models might work for them going forward. So each of these bars here represent 2019 dental student graduates in a different racial or ethnic category. So we have white, followed by Asian, then Hispanic, then Black. The yellowish orangish color shown in each of these bars represents the share of dental students in each of these racial or ethnic groups who have no student debt when they graduate dental school. And then we move from pale blue, still on the left of these bars, and that represents those students who have less than $100,000 in debt, to the darkest blue, almost navy on the right, which represents those who have more than 500,000 in debt. So as you can see, when looking just at that orange segment, a much greater share of white and Asian dental school graduates are graduating with no student debt. And on the whole, Black dentists by far are graduating with the highest levels of educational debt. Okay, so there were some big picture trends. We're going to shift gears now and get into some more recent, hot off the press, pandemic related measures we've been looking at. So HPI began polling dentists on their experiences with COVID on March 23rd, if I'm not mistaken, of 2020. So really not missing a beat. And over 2020 and 2021, we were gauging the experiences of dentists in every state across all types of practice models, geographies, etc. We've continued this polling monthly, but we have a slightly new flavor to it, recognizing that while the pandemic will hopefully be occupying less time and stress than it once did, there are other important issues in dentistry that are worth having a close, regular gauge on. So we refreshed this poll at the beginning of 2022. And it's now called the Economic Outlook and Emerging Issues in Dentistry poll. Nearly 3,000 dentists to date have opted to participate since we initiated this poll at the beginning of this year. And if any of our panelists are out there today, thank you. Without your time and your willingness to share about your own experiences, we would not be able to take the pulse on dentistry as we are now. So most of which I'll be sharing with you all today, or most of what I'll be sharing with you all today is from our most recent round of data collection, which was in mid-February. We post all of our reports and summaries online each month at ada.org/HPI, and we have breakdowns by practice size, specialty, and much more. So definitely encourage you to check it out if any of this is of greater interest. But here I'll show you some of what we've learned in the last couple months. All right, so in January, we kicked off the new year by asking dentists, looking forward the next 6 months, what are the top 3 challenges facing your dental practice? Dentists could reply with anything that came to mind. This was free response, open response, and some of the responses we got were lengthy. Quite clearly, though, staffing concerns rose to the top of the list, as you can see here with this word cloud. Also pretty prominent were COVID protocols, cancellations, inflation, reimbursement, and there's a lot of other stuff here that's causing some stress. Here's a more quantitative look at that same data. So this reflects responses to the same question, the top 3 challenges facing your practice. Nearly 70% of dentists indicated that staffing issues were one of the top challenges they're facing. Behind that was inflation, overhead, and rising costs, then insurance and reimbursement, and finally patient cancellations. So our takeaway here, staffing and inflation, rising costs are the top concerns as we're entering 2022. And that's consistent with what we saw in late 2021 as well. Okay, what about dentists' outlook on the economy? So we've been asking dentists looking ahead the next 6 months, how confident are you in the recovery of your practice, of the dental care sector overall, and the US economy at large? So dentists are pretty confident in the recovery of their practices and dentistry overall. While we did experience a drop in confidence in recent months, which is very likely due to the Omicron variant, which is also similar to what we saw last summer with the Delta variant, We did see a slight rebound in confidence levels in February, at least in terms of dentists' outlook for their practices and the dental sector. 71% of dentists indicated they're at least somewhat confident in the recovery of their dental practice. 67% say the same for the dental care sector. However, dentists are not nearly as optimistic about the US economic recovery, and it'll be interesting to see what we see with this in March, given what's going on in the world. Just over 1/3 have high hopes for the US economic recovery in the first half of 2022. Okay, so this here is one of our new core measures that we introduced at the beginning of 2022 to gauge dental practice. How full was your dental practice or your dental clinic's appointment schedule last week? Schedules in dental practices were about 83% full on average across the nation in February, representing an increase from 77% full in January. And that's represented, the national averages here are represented by that burgundy line that you see. But in teal, you see the Missouri experience. So you see the fullness of schedules in January was about 80%, so a little higher than the national average. And then in February, dropped slightly to 78%. So a little bit less full than the national average, but overall tracking pretty close. We've consistently seen some variation across different segments of dentists. We've seen this throughout our polling, but here you're looking at just the February data. Dentists affiliated with DSOs reported more full schedules compared to their colleagues who are not affiliated with DSOs. In February, dentists in urban and rural areas did not have as full schedules as their suburban dentist colleagues. And we see some variation by specialty too. We also see variation by other demographics and factors of practice too, which is all available online. Those are just a few that might be of interest. Okay, so in February, we dug deeper on this practice capacity issue too. We wanted to go beyond how full your schedule was. And we asked dentists these 3 questions. When your practice is fully staffed, what is the maximum number of patients they could see in a typical week? Then, considering your patient's current staffing situation, what is the maximum number of patients it could see in a typical week? And lastly, how many patients did your practice actually see last week? So the averages for these numbers, these metrics, isn't really all that telling because we have lots of different practice sizes and structures represented in the data. Instead, what we're showing here are the ratios that we think provide really important insights on what's going on in dental practice. So let's start with the top portion of this slide. Here, we're looking at the maximum patient volume in practices given their current staffing levels, as compared to the maximum patient volume if practices were fully staffed. On average, this shakes out to be about 89%. So current patient volume capacity is 89% of what it would be if all positions in the practice were filled. Said another way, staffing shortages are causing an estimated 11% reduction in practice capacity. All right, so let's move on to the next ratio. Here, we're looking at the actual patient volume, how many patients practices saw last week or in February, as compared to the maximum they could see with their current staffing levels, their existing current teams. And that comes out to be about 84% on average across the nation. Dental practices patient volume is at 84% of its current potential. You might recall from just a few slides ago that the average schedule was 83% full, so very similar to this 84% metric shown here. The data checks out. All right, so this staffing shortages are causing about an 11% reduction in practice capacity. And we're currently occupying about 84% of the existing capacity. So there's room to see more patients for most dentists and practices. For the majority of dentists who do not have full schedules, we've been wondering, what are the reasons why? Why do they think that their schedules aren't full? So we've been asking those dentists who indicate that their schedule is not 100% full, which factors have prevented that? In January, which is represented by the orange bars here, 9 out of 10 dentists attributed that, at least partially, to patient cancellations, and that was very likely related to the Omicron variant. We saw this decline ever so slightly in February, which is represented by the yellow bars, but 85% of dentists still reported that patient cancellations got in the way, which is a very high share. Also, more than 4 out of 10 dentists indicated that low patient demand was leading to empty appointment slots. And about 1/3 cited the difficulty they're having with filling vacant staff positions. What about Missouri dentists? Why aren't their schedules more full? So like before, burgundy represents here the US averages, while the teal bars are representing Missouri dentist responses. 57% of Missouri dentists attributed their unfilled practice capacity to patient cancellations, a lesser share than the national average, but clearly still this is a significant factor. Relatively though, similar relationships we're seeing here. Not enough patient demand is the factor that's next most common, and then that's followed by difficulty filling staff positions. Okay, so those unfilled staff positions, what specifically is that situation looking like? We've been asking dentists, have you recently or are you currently recruiting any of the following positions? And here we indicate the shares who say, yes, I am hiring or have recently hired for dental assistants, shown in teal, dental hygienists in burgundy, administrative staff in yellow, and other employee 1099 associate dentists of some sort, and that's shown in orange. So we've been tracking this since October of 2020, and in February 2022, dental team recruitment needs reached a new high. More than 4 out of 10 dentists have recently or are currently recruiting dental assistants as of February, and 35% recently recruited or are trying to recruit dental hygienists. And in Missouri, the staff recruitment needs of dentists in Missouri are very similar to what we're seeing nationally. Not much shift here. And what about the level of difficulty with recruitment? So what we're finding is that these recruitment challenges are not easing up. When we ask recruiting dentists how challenging it's been, the vast majority say it's been very challenging. So over 90% of dentists recruiting dental hygienists indicate it's been extremely or very challenging. And nearly 90% indicate the same among those who are recruiting dental assistants. Let's zoom in quickly on one private practice and public health comparison. So across the board, we know that dental team recruitment needs are high, and they reached a new high in February. However, when we compare dentists working in public health settings to those in private practice, we see that public health settings have even more open positions. More than 8 out of 10 are recruiting dental assistants, and more than half are recruiting dentists, hygienists, and administrative staff. So public health settings are feeling the effects of these staffing shortages, perhaps even more acutely than those in private practice, at least on the national landscape. And I'm sure you all could tell me a lot more about what it's looking like specifically in Missouri. So lastly, on this issue, we wanted to better understand exactly what the challenges are in workforce recruitment. So what is it that has made this such a challenging issue for dentists? We asked that. We asked that to dentists who are or were recently recruiting dental assistants and or dental hygienists, and who indicated that it's been extremely or very challenging for them. So to that subset of dentists, which is actually quite a few, we asked what specifically has been challenging. This again was a free response question. They could say anything they wanted, and then we coded it appropriately. The most common reason cited among dentists struggling to recruit dental hygienists and dental assistants was not receiving enough applications, having a shortage of applicants. For open hygiene positions, the wage and benefit requirements of the applicants is also a challenge. It doesn't seem like the wage and benefit hopes of the applicants is necessarily in line with that of the dentists or hiring managers in a lot of situations. Dentists also indicate that it's been a challenge due to receiving underqualified applications. We know that there are activities going on in some states to address the hygienists and assistant workforce shortages. There are partnerships with some dental associations, some coalitions with hygiene educational programs, assisting programs as well. But many of those activities won't have short-term wins associated. So one of the only actionable insights that we see from this data, at least in the very near future, is that wages may need to be raised, especially for hygienists. And this is not unlike what we're learning from other sectors in healthcare and more broadly. Okay, so let's get into the final section here, and then I'm happy to entertain questions. We're going to talk about some Medicaid research that has come out from HPI in the last year or so. So we collaborated with Families USA and Community Catalyst on an analysis last year. We estimated the fiscal impact of implementing more extensive adult dental benefits in states without those benefits in their Medicaid program, so that low-income adults can get the care they need. The literature is clear that this not only impacts oral health and overall health status, but can improve employability prospects and economic productivity, and that those with chronic conditions like diabetes and heart disease can achieve better overall health and oral health status that results in reduced medical care costs. And those with more expensive benefits have somewhere else to go than costly emergency rooms that, as you all know very well, are typically ineffective for treating these conditions and often result in a revolving door of unresolved dental issues. So dollars that really aren't very wisely invested. I know I'm preaching to the choir on a lot of this. So just quickly reviewing the current landscape, as you know well, I'm sure, Missouri is one of 16 states that currently provides what we consider to be limited dental benefits to its adult enrollees in Medicaid. And that's according to a classification system that certainly isn't perfect, but one that's been used by us and by others in this space, like the Center for Healthcare Strategies, as well as the National Association for State Health Policy. So why do adult dental benefits matter so much in Medicaid. I know some of this, again, is preaching to the choir here, but I hope that these stats are of interest to you and maybe something that you can take in your own work. So among individuals who are not able to get needed dental care, the primary barriers all relate to cost. So cost barriers are far more prominent than any other access barrier, like say, for instance, transportation. So what do we take from that? Coverage is important. And compared to other health services, as shown here on this slide, cost barriers to dental care stand out. They are higher, cost barriers are higher for dental care than they are for mental health care services, medical care, and even prescription drugs. And of any age or income group, low income adults face the most significant cost barriers to care. So that's shown in these middle set of bars. We've broken this down by age with children up top, adults, and then older adults shown below. You can see in that burgundy bar in the middle that about 1/3 of low income adults with low, or excuse me, 1/3 of low income adults indicate that they needed dental care at some point in the past year, but were not able to get it due to cost. So here I show the takeaway from this analysis that we did in partnership with Families USA and Community Catalyst. Honestly, this national picture might not be all that exciting to you all, but we do have a Missouri analysis that's a part of this as well. So our estimates as they relate to Missouri are included in this paper. And I'll make sure that you all have access to that, easy access to it. It is publicly available online. But one thing I do want to note is in this analysis, we were not able to factor in the cost savings from diverting care from emergency departments, which is a huge factor in the economic analysis of this. And it was simply due to data constraints and frankly, where certain national data systems work. Some excellent data has come out of CMS with Dr. Natalia Chalmers. And there's some excellent, new figures in terms of cost for this. Had it only coincided a little bit better, we may have been able to factor some of her findings into this. But the point is that our analysis is really quite conservative because we're not accounting for the savings we would see from diverting care from costly emergency departments. Okay, switching gears a bit, we've also recently updated our analysis of Medicaid reimbursement rates as compared to private insurance reimbursement rates. I'm happy to discuss, methodology for anybody who's interested in this. We do often get questions about what goes into this work. Happy to address that. But I want to show you the high points here. So in 2020, Medicaid reimbursement was on average 61.4% of private insurance reimbursement for child dental services. So this is a slight decline from what we saw in 2017, which was at 61.9%. And in Missouri, Medicaid reimbursement was 46.4% of private insurance reimbursement for children's dental services, clearly lower than that national average. All right, for adult dental services, we saw that Medicaid reimbursement was on average 53.3% of private insurance reimbursement in 2020. This represented an increase from our last count in 2017, which was at 49.3%. And in Missouri, you can see that Medicaid reimbursement for adult services was at about 48.5% of private insurance reimbursement. Again, lower than the national average. What about dentist participation in Medicaid? So some of you might be familiar with this infographic or some past iteration of it. This one shown here was released in the summer of 2020, but don't look too closely because there's newer data that I'm about to share. But one of the shortcomings that many people recognized, including us, when we were doing these measurements before, is that we were measuring provider enrollment as provider participation. So simply dentists who had signed up with their state's Medicaid program to be able to bill for services. And that method of measurement based on enrollment only was purely due to data constraints at the time. We all wanted something better, and now we do indeed have it. So we're using new tools at our fingertips. We used newly accessible Medicaid claims data from almost all states to measure dentist participation in Medicaid according to different metrics, more refined metrics. So not only limited to provider or dentist enrollment, but also incorporating an analysis of the number of patients served who are covered by Medicaid. This obviously makes for a much more meaningful analysis of provider engagement with Medicaid. As an example of our new measurement methodology, here we're showing 3 states, Vermont, Wyoming, and Michigan. According to HPI's old metric on dentist participation, all 3 states would have had 71% participation, or 71% of dentists being enrolled in their state's Medicaid program for child dental services. And that tells just part of the story, just a small part of the story. So in each of these 3 bars for these 3 states, we move from the left side, which, as you can see, is very pale pink, and that represents the share of dentists in the state who are not enrolled in their Medicaid program. And then we go to light pink, and that represents the share who are enrolled but not seeing any Medicaid patients. And then we get into the darker pinks and eventually purple, really, where we go from the enrolled providers who are seeing 1 to 9 Medicaid patients in the year, then 10 to 100 Medicaid patients in the year, and finally 100 or more Medicaid patients in the year. Again, all 3 of these states have 71% of dentists enrolled. So that's the entire bar, less that lightest shade of pink, almost off-white color that you're seeing on the left. But in Vermont, more than a third of dentists are seeing more than 100 Medicaid patients in the year. And in Michigan, only 1 in 10 dentists are seeing more than 100 Medicaid patients in the year. So the level of engagement that dentists have with their Medicaid program varies drastically, even when we hold enrollment in the program constant. All right, so there's a lot here and it's tough to read, but again, you'll have links and this is all available online to take a closer look. But here we've ordered states according to the share of dentists who are seeing more than 100 Medicaid patients in the year. That's the deepest shade of pink, really purple, burgundy, I guess, at the top of each of these bars. So we start with the states who have the highest share of those dentists seeing more than 100 Medicaid patients: Vermont, Mississippi, and Montana. And then we move to the right side of the slide where we have the lowest share of Medicaid providers seeing that threshold of 100 plus patients. And there we have Utah, Virginia, and Maine. I imagine that we might see some shifts in this because of changes some of these states have had recently. Okay, so what about Missouri? 32% of dentists were enrolled in Medicaid. However, 16%, so half of the dentists enrolled, weren't seeing any Medicaid patients in the year. And at the opposite end of that spectrum, there are 12% of Missouri dentists who are seeing more than 100 Medicaid patients in a year. There are 3% who are seeing 10 to 100 patients in the year, and 1% seeing 1 to 9. So our hope for this was that be useful for policymakers and oral health advocates, as you all can use consistent but flexible definitions of provider participation and engagement as you all look at programs in your state to try to figure out where improvements can be made. So some of you might be thinking, what are the learnings when we kind of combine the research on reimbursement and then we look at provider participation? So we ran that analysis, and here let's just start quickly with the graph on the left. We've plotted states by their Medicaid reimbursement rate as compared to private insurance on the horizontal axis, and the dentist participation, the share of those enrolled in seeing at least one Medicaid patient on the y-axis. That dotted trend line that you see is pretty flat, but it does have a slightly positive slope. So that tells us there's at least a relationship, but it's a pretty weak relationship between reimbursement rate and dentist participation in the state. If you look at the graph on the right, it's relatively similar, and I want to alert you that the scale shown in each of these is a little bit different. But on the y-axis, on the vertical, is the share of dentists with at least 100 Medicaid patients in a year. So again, a pretty weak relationship. What we take from this is that on a very basic level, without controlling for any other factors, higher Medicaid reimbursement rates do not necessarily result in increased or robustly increased provider participation. But I think one way to think of this is that adequately funded programs that appropriately are reimbursing dentists for their services are an absolutely necessary aspect of the program design, but it's not necessarily sufficient for recruitment purposes. So this isn't to say that reimbursement rates aren't important. We all know they are, but there are likely many other factors at play here. Okay, so I do want to get to some questions. I'll just quickly fly through some, overarching takeaways from some of the information shared, then absolutely want to open it up. Practice consolidation, we know it's going to continue to accelerate, and we'll have more information coming out on this very soon, next week, in fact, and hope some of you can join us for that. The demographics of the dentist workforce are indeed shifting. We're seeing a higher share of practicing dentists who are female. We're seeing some shifts in the racial and ethnic categorizations of the dentist workforce, but not necessarily reflective of the US population. We know that staffing shortages and rising costs are a huge factor for dentists. We believe that staffing shortages have caused about an 11% reduction in practice capacity. And we know that dentists are struggling because they're not receiving enough applicants for dental team positions. They're getting some underqualified applications. And we know that wage and benefit requirements might be shifting too on the dental team. Schedules in dental practices were about 83% full, and those gaps are largely due to patient cancellations. Confidence in practices remains high, as it does for the dental sector overall, but most dentists remain quite wary of US economic recovery in the near term. And we know there are significant opportunities to improve access to dental care and reduce disparities via robust oral health programs in Medicaid. Some aspects that really need to be looked at closely, more closely than even we've shared here today, are dentist engagement in Medicaid programs, as well as reimbursement rates. That gives some solid ground for exploring other improvements. So with that, I will turn it over to you all, and I'd be happy to take any questions. I really thank you for your attention today, and hope this spurs some more conversation.
Thank you, Dr. Foss. We do have some questions ready. I'm actually going to invite our questions to come up to the podium so that you can interact with Dr. Foss if you would like. So Dr. Taylor, do you want to start us off?
Morning, Dr. Foss. Can you hear me all right?
Hi. Yes, thanks.
Right. Thanks for taking the time today. And I would like to first say thank you for all of the work that ADA and HPI have done since the pandemic had started. You all have kept in constant contact with us, and this information is extremely useful. My question sort of revolves around the ownership of practices, and it's worrisome to me as a rural practitioner seeing the retirement of so many of the baby boomer generations, folks who had a private practice set up and they've been in practice for 30 to 40 years. They're having to walk away from their practices in small locations because nobody wants to go to that location or nobody feels like they can afford to buy a practice. I'm a little bit probably hypocritical here because I'm not in private practice, I'm in public health, but do you see a continuation of decline in private practices versus group partnerships, DSOs, that sort of situation? And not that you can read the future, but is it trending more towards how medicine has gone in the last 15 to 20 years? There's no private medical practitioners anymore. Everything's governed by red tape and insurance. And are we going that direction as well? And dear God, if we are, hold on to your butts.
Thank you for your question. And yeah, there's a lot to unpack there. But generally speaking, as I think you've hypothesized and taken away from some of what was shared today, we do see a continuation of most of these trends and the downward trend with solo ownership, absolutely, but ownership overall as well, that might not be as rapid of a change. We are seeing more and more large group practices. And I think to some extent, there's really been a shift in even the DSO models and how they're involving dentists as owners. But yes, I mean, the trends again that we showed today, we do predict that those all will continue onward. I think you're obviously bringing up a really crucial point, especially regarding rural access to care and what we're going to see, what we can expect with that. And I think that there are going to need to be a lot of hard discussions about like how do we really be influential in driving dentists to these opportunities, particularly new dentists. I know the ADA has some efforts in this regard to really start trying to promote these areas that maybe new dentists have not been thinking about as quickly to establish their careers in areas that have great perks and great cost of living. So hopefully we do start to see more innovation in terms of like the geographic distribution of dentistry. I know it's been something HPI has been concerned about for a while, and we've worked really closely also with HRSA, the Health Resources and Services Administration, on like measuring health professional shortage areas, and obviously those activities are all really important in terms of designing whatever programs might make sure that these areas still have access to dental care and can still be a viable place for a dentist to operate. In terms of retirement patterns, yeah, so again, next week, actually, we're coming out with some new data on this. until end of 2021, based on what we were like tallying to date, we actually had not seen a significant uptick in retirement. Part of that was due to our data collection methods and kind of the lag of in terms of what we were learning. And indeed, we did see an uptick with retirements in dentistry. So I think, you know, that you're right that in a lot of areas there's probably a significant struggle with the supply and demand of dental practices not really balancing out well for those who were currently or are currently owning those practices. So I don't, you know, mean to like incite any fear, but I think it's wise to know that we do see that dentistry in many ways will start to, over many more years, start to look more and more like medicine, likely, where the small practice owner might become more rare, and this is over potentially many years, that there will, you know, be more consolidation. Hopefully, looking optimistically, there will hopefully be better integration with health services too, and more people on the health and the medical side recognizing the importance and the partnership on the dental side. So there are pros and cons to these shifts we're seeing, like culturally and in the profession. But yeah, I thank you for your question. I'm sorry if I'm not answering it adequately.
Thanks a lot for your time, Doc. Appreciate it.
Good morning, doctor. My name is Angela. I just had a point of clarification that I would like to ask. Was your data regarding the dentists on your beautiful bar graphs that you had, is that based on license number or is that based by practice type? And is it differentiating private practices versus FQHC dentists? Thank you.
Great question. Yeah. So that data is from the Medicaid Claims National Data Set, which is called TMSIS. It's a acronym that's a long drawn out name, but we use NPI with that. So there are some shortcomings of that analysis. One of those shortcomings is that in settings where the setting is listing perhaps a dental director as the rendering provider versus another dentist on staff or something, we're going to have an undercount in that area. We did use rendering provider versus billing provider for that reason, but the way in which claims are sent by different facilities and tallied by state Medicaid agencies before this data goes off to CMS does vary. So we recognize and we've acknowledged that in the work. But in answer to your question, it's based on NPI.
Good morning. My name is Dr. Richard Campos. I practice in the Kansas City area. My question relates to the shortage in the workforce, particularly with dental assistants. So here, we all have difficulty hiring well-trained dentists. And when I started asking some of my assistants the cost of their training, I think it became a little bit clear of why it's so difficult to find assistants. These assistants I've talked to for their program that is less than a year, that isn't even an associate's degree, was costing them $25,000, $30,000. So I was just curious, does the ADA look at or track the average costs of some of these programs, or the cost of what some of these schools charge? And then does the ADA in any way sort of help these assistants in fighting these borderline predatory loans?
Yeah, great questions again. Thank you, Dr. Campos. So, yeah, so there's some data we have that's kind of a collection between, it honestly hasn't really primarily been captured by HPI, but some data available by CODA and some from ADEA, the Dental Education Association. They have some information on this. It's quite minimal though. So we've kind of shared across these groups. But yeah, I mean, these issues are definitely being brought to the forefront. One like tangible, exciting thing that's happening with this right now is that the ADA has been lobbying pretty heavily on funding some pipeline, getting federal funding for some oral health workforce training programs we know that a lot of hygiene programs have closed. The same thing is happening with dental assisting programs. They're just realizing that the economics for even having the school, let alone having high tuition, is not working out for the institution on a larger level. So we've seen some of these closures. And I think more than ever, we've been really actively involved in trying to get some funding that would, go to the sustainability of these programs and hopefully subsidize at the tuition level so that it becomes a more realistic option. Your point is well taken. It is looking in different states at the costs of what these programs are, and then going into practice and seeing the average hourly wage. You have to commend them for making a smart decision when it just doesn't make sense. So yeah, I mean, I'm very hopeful that we'll see some more activity on the federal level in terms of financial support for dental team programs.
Hi there. I'm Diane Baumkamp. I'm a hygienist from Missouri. And one of the questions I had when we were looking at the data from January to February and how many cancellations there were, I was wondering if you looked at the weather situation. We had many snow days, and I think across the United States we had that as well. So I'm feeling a little bit more optimistic than the numbers showed on that. Thank you.
Yes. No, excellent question. And actually, I should have commented on this. So there was, on these questions, there's a checkbox that's other, and then we do ask people to leave a comment and tell us. And for both January and February, the number one response that we got in that group that indicated some other factor was inclement weather. And if we only had more time, we were actually going to try to look at some like meteorological data, do some where we had enough responses, do some state to state comparisons. But yes, we do think that the patient cancellations is not only a factor of what was happening with the Omicron variant, but also due to seasonality, weather shifts too. Great point. Thank you for bringing that up.
Do we have any other questions in the room? Okay. With that, help me thank Dr. Foss again for the wonderful presentation.